Well, good morning, everyone. Welcome to the University of Louisville Department of Psychiatry Grand Rounds series. It's certainly my pleasure today to be introducing our speaker for today, Dr. Nicholas Trapp. So I actually got a chance to meet Dr. Trapp. He was in town about a few months ago. He was doing grand rounds actually for neurosurgery. And it's wonderful to have him back to do grand rounds for psychiatry. For folks that don't know him, Dr. Trapp is currently an assistant professor of psychiatry at the University of Iowa, where he is the director of the Interventional Psychiatry and Psychiatric Neuromodulation programs. He co-directs the Interventional Psychiatry residency track and the Sidney Bear Neuromodulation Fellowship. Dr. Trapp completed his medical school at the University of Nebraska, and after that, he went to Washington University in St. Louis, where he did a postdoctoral fellowship. He completed a neuroimaging and neuromodulation postdoctoral fellowship also at the University of Iowa. And after that, he went and did a behavioral neurology fellowship at Stanford University. So he's got a tremendous amount of training that really sets him up very well to do what he's doing now, working with interventional psychiatry program. And I just want to say, it's really important that people understand that interventional psychiatry is a huge part of the future of psychiatry. So it is important, whether you're interested in TMS or not, it is important that people be very comfortable with what Dr. Trapp is going to present today. His actually has done a fair amount of work with neuromodulation and TMS. He's received awards from both the American Neuropsychiatric Association, and he has also received funding from NARSAD. His research focuses on understanding the mechanisms of brain stimulation, exploring methods of optimizing brain stimulation for neuropsychiatric indications beyond depression. He will be speaking today to us about TMS for depression and telling us what's new and how we can make it better. So, Dr. Trapp, I would very much like to hear what you have to say to us today.
Great. Thank you so much, Rip, for the introduction. And thanks for Megan and Audrey and everyone else who sent the invite for this. It's great to be virtually back in Louisville. Yeah, my first time there was just, I think, 8 months ago for the neurosurgery grand rounds. It was great to experience the city and try some bourbon and all that good stuff. So yeah, I'm going to be talking about TMS for depression, and I realize that that maybe isn't in the wheelhouse of everyone in psychiatry. So I'm going to start kind of from the basics, but towards the end also get a little bit more complex. So I don't know if the chat feature is enabled for people on this call, but if it is, I'm more than happy for people to put stuff in the chat as we go along here, and I'll try to keep an eye on it. Otherwise, hopefully I'll finish well before 90 minutes. I usually get bored of hearing myself talk after about 45 minutes. So we'll try to finish within the first 45 to 60 minutes and then leave time for questions. So, okay, Q&A feature for questions. Perfect. Okay, so TMS for depression, and I'll talk a little bit about why I'm talking about this now. Obviously, it's a research interest of mine. You don't have to wear Bono-style glasses to do TMS. We were just taking a funny picture for our lab website. So that's me and my clinical trial coordinator and one of my graduate students. Okay. So here are my disclosures. The only thing I'll mention is I will discuss some potential off-label uses of TMS. I'll try to make that clear when I bring those up. Otherwise, I don't have any conflicts with this topic. All right, so I'm going to start with this, which has become a relatively, I'd say, popular, well-known thing in the neuromodulation space, which is the Stanford SAINT protocol, or the Stanford SAINT study. I know we can't do a show of hands on Zoom here, but I'd be curious to know how many people are familiar with this study. And you see in this article online, they're portraying this as a pretty glorious new treatment option. And I think this is a very, very exciting protocol in the area of TMS. So what is the SAINT protocol? It's basically a really high dose in personalized treatment protocol using TMS that is achieving in small studies very, very high response and remission rates. And I was not part of the original trial, but I was at Stanford at the time this was being conducted, and I was in the lab of Nolan Williams, who is the PI on this study. And so I got to see some of these patients, and some did have pretty remarkable responses. So in their initial publications, they reported 80 to 90% remission rates for treatment-resistant depression patients, and in some of those studies, very treatment-refractory cases, and really no serious side effects from the treatment. I'll talk about some of the potential side effects of TMS, but usually it's just a tapping on the head can induce a headache, could potentially cause somebody to have some scalp tenderness. The most serious concern is usually a seizure, and a seizure, no seizures happened in these trials. So really high response and remission rates, no serious side effects. And they actually achieved a breakthrough FDA status and got FDA clearance after these publications in 2022. So this has now been FDA cleared for a year and a half. And we'll talk about maybe why it hasn't taken off yet. But it's there's a company that's been built around this called Magnus Medical, and they're gearing up for mass marketing of these new devices and protocols. So I bring this up as kind of like a very impressive utilization of transcranial magnetic stimulation. And what were kind of the unique aspects of this, if we look at the SAINT protocol compared to other standard TMS protocols we use for conditions like depression, what was different? So usually a standard protocol, we do 30 sessions of treatment over 6 weeks. You do once a day. This condensed that and did 150 basically session equivalents over 5 days. So it's extremely high intensity. These patients were in the hospital or were in the outpatient setting 10 hours a day getting these treatments. They also used a targeted functional connectivity-based algorithm for finding the prefrontal cortex based on functional connectivity. That's a proprietary algorithm, so it's not available to the average TMS provider right now. They also used a personalized dose, so they adjusted the dose based on the distance between the scalp and the cortex, and specifically the prefrontal cortex. And again, being kind of there when this was going on and involved on the clinical side of these things, they really had rigorous patient selection with a really extensive and thorough review of these patients' histories to rule out comorbidities and ensure, they were treating pure depression. So here's kind of what that targeting looked like. The blue dot is where a lot of standard TMS is targeted, and each of those little individual dots is the individualized targeting for this study. So showing that, these might be different targets based on the individualized connectivity. And here you see the active response in gray and the sham response in the circles, the darker gray, and achieving an effect size of about 1.4 to 1.8 at any given point in time. So really, really impressive results. This double-blind trial had 29 patients, and it was terminated at, I think, the halfway point because of how big the effect size was. It was determined to not need to continue to completion because sham and active had already separated. So really impressive early response or early evidence for this protocol. So I think then there's been kind of people questioning, like, is 90% too good to be true? And this is from another website that was writing about Saint TMS. And I think what a lot of people are asking with this is, like, what's the secret sauce here? Like, what combination of all these things that are different from our standard treatments is making this so amazingly effective? Obviously, there's been some replication of this, also small studies at this point. There are plans for more. But if I had to break it down into, like, what are the three things this trial's done that other trials didn't do, that I would have to put my money down, is like, what's different here? One, maybe is it choosing the right patient? Two, is it the accelerated protocol, so just a lot more treatment? Or is it the targeting of the treatment using this individualized MRI-based connectivity? So, so that's kind of open for debate, and something I'll try to unpack here over the next 45 minutes or so. So this got me thinking. I was like, I'm giving a talk at the University of Louisville. How do you discover the secret sauce? There's one way, there's science, and there's also just serendipity, maybe just happenstance, you come across a discovery. And, you know, serendipity is how the KFC top secret recipe was discovered. I don't know if people follow this. I'm a huge fan of KFC. I used to go there for my birthday for, like, probably the first 15 years of my life, because I just loved KFC. So I went down a deep rabbit hole looking at KFC. I know KFC is not in Louisville itself, but in Kentucky. And so there's this story in 2016 that this gentleman, the nephew of Colonel Sanders, found the 11 herbs and spices that were the secret KFC recipe. And in an interview, he divulged these to the media. And I guess that was a big deal at the time. And so then the journalists kind of asked KFC's parent company, Yum, you know, is this the recipe? Can you tell us? And they just said, lots of people through the years have claimed to discover or figure out the secret recipe, but no one's ever been right. So is this the secret sauce? We'll find out. I'll show maybe some attempts at this as well as we go along. So we're looking at the secret sauce for Saint, but we're also looking at the secret sauce for KFC and their chicken. And if anybody wants to put in the Q&A, if you've ever tried this secret recipe that was divulged in 2016, I'd be really interested to know if it's good. I've never tried it. All right. So Saint is now being adopted. Like I said, there's a proprietary algorithm for the actual targeting protocol. So you can't use real Saint or the FDA cleared version of Saint, but there's a lot of people that are using this Saint-like protocols. And I think this, you know, is an important thing to look at, the secret sauce, because people are paying, you know, if you poll around the country, probably on average 20K or more out of pocket to get a Saint-like protocol. So 5 days of treatment, very intensive treatment, unclear durability, although there's actually been some good studies looking at durability recently that are coming out. So is this Saint? This is a deep TMS coil. So if you use a different TMS coil, is that the same? Is that Saint? What if you use your own targeting algorithm? So there's companies that are, or clinics that are developing their own targeting algorithm, saying this is similar to what Magnus is using. We'll target based on this. It'll probably find the same target. You're good to go. We'll do the same protocol. So there's people paying a lot of money for these things that are Saint-like, and we don't know exactly how efficacious they are individually. And so this, along with a lot of other things, back in 2022, around the time Saint came out as FDA cleared, to look at developing a task group or a work group to develop updated consensus recommendations on the use of TMS for mood disorders. There was a document that was first authored by Sean McClintock back in 2016 that did this and kind of came out with some initial guidelines. And so this is kind of like, there's a lot that's changed in TMS over the past several years. And so we need kind of an updated version. Sorry, I was getting a little feedback there. But I know you guys are a member of the NNDC, as are we, and here's kind of the primary, I think 21 sites. There's additional sites there, and several of the institutions had representatives on this work group. And I will say these recommendations are unofficial at this point. They're not published yet. They're still in various stages of being refined, but they're mostly finalized by the work group. All right, so that's kind of a brief thing on. I'll get back into all those topics as we talk through here, as to kind of what our recommendations are and all these secret sauce things. But first, I'm going to backtrack just to make sure I get everybody on the same page with what TMS is, because like I said, I know not everybody does this all day, every day. So what is TMS? TMS stands for transcranial magnetic stimulation. So transcranial, something that passes non-invasively into your cortex using a magnet or a coil sitting on the head. It's magnetic, so we're passing electricity through a coil, but that induces a magnetic field that goes into the brain. And then it's stimulation. So in general, we're using this to depolarize neurons. And by doing that repetitively, we can modulate cortical function, change sometimes gene expression factors in the region of the stimulation. So here's me doing a demo for the dean of our medical school. And it reminded me of this GIF of this guy whose head is exploding, or having a mind-blowing experience here. All right, so kind of a one-slide recap of principles of TMS. So like I said, is electromagnetic induction of neurons. The signal travels transsynaptically. So we know that, like, if I stimulate my motor cortex, I'm going to have an output in my hand, even though that's not the exact same neuron, right? It's going down the corticospinal tract and synapsing in the spinal cord. It stimulates focally. At least the signal of depolarization is focal. How focal is the stimulation itself? We'll talk a little bit about that. There's reason to believe it's not actually that focal. And then also, in general, on group averages, you can have parameter-specific effects. So I can stimulate an area of the brain, and I can excite that area, or I can inhibit that area. There's inter-subject variability, but on group averages, I can do that relatively reliably. And then the effects can last beyond the time of stimulation, and that's how it becomes useful for something like treating depression or treating other brain disorders. You stimulate, and then the patient has benefits that last hours, weeks, months. So here's kind of what a coil looks like, what the magnetic field looks like around the coil when you discharge the coil. Like I said, you'll pass a signal if you stimulate motor cortex that goes down into motor neurons in the spine and then out to whatever the target muscle is. And you can see here you get a TMS pulse and you get a motor evoked potential about 30 milliseconds later. How do we know that this is so focal? We can use this actually for mapping language and motor areas of the brain. Here's an example of doing that for pre-surgical mapping. So trying to find what areas of the brain do we not want the surgeons to cut into when they go to surgery. So you stimulate with TMS all over the motor cortex. You see what muscles are controlled by the different regions of the brain. And you see here, like this yellow dot is an area where you get a strong action potential. The red are kind of areas where you're getting weaker action potentials, and then black is you're not getting any action potentials there related to that muscle group. So you can move the coil a couple millimeters and start to lose your action potential, suggesting this is a relatively focal response. And like I said, we have protocols that are excitatory, protocols that are inhibitory. In general, higher frequency or higher pulse per second stimulation tends to be excitatory, although there's a lot of caveats there we can talk about that aren't going to be super pertinent at this point. So that's one slide. How does TMS work? What does it do? How can you modulate the brain with it? So how do we apply this for mood disorders? So a typical treatment course, and this is kind of what was initially FDA cleared back in 2008. You do a 10 pulse per second or 10 hertz RTMS protocol to the left dorsolateral prefrontal cortex. And usually you're doing 3,000 pulses per day for 4 to 6 weeks. You do treatment 5 days a week. So 30 treatments is about 6 weeks of treatment. And you get pretty good response rates with that. So this was a study of 307 people, kind of garden variety depression, comorbidities, things like that in a real world outpatient setting. And so in general, you get about a third of people into remission by a couple different measures here, and you get 50 to 60% into who just have a response. So there's still about a third of people who don't respond to this. However, these studies have been conducted in people who've already failed at least a couple medications. So this is usually a treatment refractory population. And then when they get well, how durable is it? There's not a ton of durability data. Probably the best study I could find is if you treat somebody and you look at the responders, 3 months later, about 2/3 of those responders are still well. 6 and 12 months later, about half of those responders are still well. So it seems to have good durability for at least a subpopulation of those responders. Like I mentioned, headaches, dizziness, fatigue are kind of the potential side effects. And seizure risk is the most concerning side effect. That's why people have to come into the clinic to do it. We can't just rent them a device to take home. But that risk is exceedingly low. So depending on the study, it'll be somewhere between 1 in 10,000 up to 1 in 30,000 treatments. Oh, sorry, I'm getting a phone call here. All right, and that risk may be higher for deep TMS, which is TMS devices that stimulate deeper into the cortex. So here's kind of how this looks at Iowa for people that haven't seen TMS before. So you have the patient kind of sitting in a recliner chair. You have a metal arm that'll hold the coil in place once you find the target. We have our technician. This is Chris. He's awesome. Our patients love him. And then we have a supervising physician who will be in the room for just critical parts of the protocols, but not the whole time. Usually the technician's doing the vast majority of the work. And you don't need that neuronavigation system in the background. That's just what we use for those speech and motor mapping studies. And a lot of research protocols use that. Like I mentioned, the SAINT protocol does use neuronavigation targeting, but a standard clinic wouldn't use that. All right, so I'll talk a little bit about our current NNDC project and kind of how we started to develop our consensus guidelines around this. So we got a group of 18 of us together. It's always hard to get consensus the bigger the group gets, but we did a decent job with 18. And so it was a narrative review. We did a kind of systematic search of the literature, but then it's not a systematic review of the literature, because as you'll see, the amount of literature in the TMS space has just exploded in recent years. And we reviewed pretty much all the data up until 2022 September. So all the data that was new from the prior recommendations. And then we also added just key articles between September and this month, actually. So you guys are literally the first people that this is being presented to. I haven't given this presentation in this structure before. So after we got all the articles, we did an abstract review and excluded things like non-English language, commentaries, duplicates, animal studies, just anything that was primary data on mood disorders and TMS, we included. And here's kind of our search terms, just to give you a sense. We kind of looked at everything depression, everything TMS, but not anything outside of depressive disorders. So we looked at bipolar depression. We didn't look at bipolar disorder more generally. All right, and then we got our 18 people. We all came up with a consensus of 11 topics that would be kind of relevant within the space to update the TMS community and other physicians on. Our team here at Iowa kind of scoured the literature to find keyword manuscripts and articles related to those 11 topics. And then we chose topic leaders for each topic, and those people came up with the original presentation of the data. And then we all discussed it as a group and used this modified Delphi method to achieve consensus, which basically means we anonymously provided feedback and rationale for our thinking on a bunch of topics, and then iteratively did that until we came to consensus. And as you'll see, there's some things that consensus was not very exciting or we didn't come to consensus about, but the majority of things we did. And then the topic leader or myself drafted recommendations, and we got feedback from the group. So who were the authors? Here's the author list. I think we've got some great people from all across the NMDC, all across the US. This was limited in that it was not international, but we have some big name people in TMS here. Only 13 of our 21 NMDC institutions were represented, and we don't have Louisville represented here. So if there's anybody out there who wants to be the Louisville neuromodulation person, I'm sure we'd love to have you on the neuromodulation task force. But otherwise, a great group of people. And here's kind of the 11 subsections I mentioned that we felt were important things to review for the community. So we talked about efficacy and safety. Then we talked about like predictors of response, special populations, coil design. There's a bunch of different TMS coils now that all do slightly different things. There's targeting methods, stimulation protocols, treatment optimization. Those are all things I'll talk about today. And then I won't talk about some of the more administrative aspects of this, but you hopefully will be able to read this article in the near future. So here's kind of just showing how mammoth of a task this was. The number of articles that were included after title and abstract review was almost 2,400 that had to do with depression and TMS, all just published within a 6-year period. So it's just a massive amount of data coming out that's really hard to synthesize. And you can see kind of the number of abstracts that fell into each of our specific topic categories there. And then additional articles were added by the topic leaders if needed. So first, just briefly about efficacy. I think there's still some, I think somebody might be unmuted here.
Hey, Dr. Caudill, your microphone is unmuted.
Yeah, probably.
I don't know if I can mute it.
Yeah, I think you can request that he mute it. I cannot because I'm not on the panel, but
I think thank you, Dr. Caudill. So efficacy of TMS, I think there's still some people that are kind of non-believers in TMS. And so this was what I think is the largest or one of the largest meta-analyses of randomized sham-controlled trials. So there's 3,000 patients at least that have been in a randomized controlled trial across numerous studies in numerous years. And you see here the efficacy or effect size is about 0.79 favoring active treatment. So it's a moderate to large effect size. This is incorporating mostly treatment-resistant patients, but people kind of across the spectrum of severity of mood disorders. So where does TMS stand now in terms of FDA clearances? It's FDA cleared for major depressive disorder, migraine headaches, OCD, smoking cessation, and then anxiety comorbid with depression. So if you have anxiety symptoms and major depressive disorder, there's a clearance for that, kind of a unique category. Like I said, the effect size is 0.79 across these large studies. And I'd say if there's areas I'd keep my eye on, the areas that seem to, in reviewing a lot of the efficacy data, have a lot of promising evidence coming out, would be chronic pain disorders and neuropathic pain, stimulating the primary motor cortex usually, and then also depression due to other conditions like stroke or Parkinson's disease. I was actually really surprised the depression in post-stroke population TMS literature is pretty strong. Bipolar depression often comes up, and I'd say at this stage has mixed results. Some studies that have shown it's helpful for bipolar depression. In most studies, the mania conversion risk is about the same as just the general bipolar population. So there's not much of a manic switch risk, except there was a recent theta burst study where a couple patients in a group of, I think, like 30 to 50 converted to mania. So there is, I think, some may be concerned that we need to explore that more, the mania risk with theta burst. All right. So maybe patient selection is the secret recipe. I'll talk a little bit about kind of our our data on patient selection. So here's a Pinterest site that got the Colonel Sanders secret recipe. You know, now it's everywhere. Everybody's got it. I imagine everybody's trying this delicious chicken. So maybe secret recipe of Saint is the patient selection. And like I said, they were very rigorous in the Saint trial looking at this. Here's kind of our review of recent literature on predictors of treatment response to TMS. In general, I think the take home here is that there's nothing that is so strongly a positive or negative predictor that we wouldn't treat somebody for it. However, pretty reliably, females have a stronger response than males. Age has been highly mixed in the data. Some people have found that older people respond better. Some people have found that younger people respond better. And then I'll talk a little bit about the evidence for like medications and their effect on treatment response. The other very notable thing I think with TMS is comorbid conditions. So like I think like with ECT, with other conditions, we often think like somebody with a personality disorder is going to be less likely to respond to our treatment for who may have comorbid major depressive disorder. The studies to date on like OCD, borderline personality disorder, autism, anxiety suggest that really it has no effect on the response rates, which is fascinating to me. You know, patients, these are not negative predictors, at least based on the data we have to date, as they might be for other treatments. I guess, evidence for negative prediction that was the strongest was probably the duration of somebody's illness. And then there's mixed findings for a bunch of other things like the history of ECT, baseline severity, the type of depression. So Colonel Sanders' secret recipe, did they get it right? You won't believe it, but they got it wrong. So maybe Yum was right. People cannot get these recipes. I don't know which one's better, but depends on how much paprika you like. All right, so back to Saint. How did the Saint trial apply this? Did they select away from some of these negative predictors and towards the positive predictors? In short, I would say no. So they took moderate to severe depression. They took people kind of across the age spectrum, and they had moderate to severe treatment resistance. They were on a stable medication regimen, so that is a positive predictor of response, is being on medication. They were excluded if they had a primary psychiatric condition other than depression, but like I said, that might not matter so much. And they did exclude people who didn't have a response to ECT, although again, not clear how much that matters. You saw in the table there, benzodiazepines in general may be a negative predictor. Psychostimulants may be a positive predictor of response. Again, only retrospective data in those categories, but they did not select differently for those. 13% of the subjects were on benzos, 3% were on stimulants. And they did not select away from people with long illness durations. So the average duration of illness in their population was 26, with 9 years in the current episode. So it was pretty rigorous in that regard. So what have we done at Iowa that's kind of contributing to this literature? This is probably the closest thing looking at predictors, which is psychological well-being. And so the interesting takeaway here is at Iowa, at least, our patients with baseline positive well-being were more likely to respond. So even if they had severe depression, if they rated themselves as having a high level of well-being at baseline, they were more likely to respond. And we used the scale called the RIF scale, which is a validated scale of well-being. And interestingly, not just well-being, psychological well-being in general, but specifically somebody's rating of autonomy, which is kind of their sense of independence and their personal growth, or their basically, I guess the simplest description for that would be somebody's openness to experiences, kind of similar to on like the NEO personality scale. So those things at baseline, if somebody said that they were very open to new experiences, their chance of responding to treatment was greater. So maybe patient selection doesn't seem to be the secret recipe. How about stimulation dose or stimulation targeting. And this gets into, I think, some of the key questions related to the SAINT trial. So if you asked me what the secret recipe is at Iowa, I would say it's probably our staff. Our patients absolutely love our technicians. And I would say if there's one thing you can do to enhance treatment response is to have good supportive staff. Colonel Sanders knew this too. He had some great staff, chicken lovers with him. So for the rest of this talk, I'm going to talk about kind of how to optimize TMS. And I'll give a patient scenario, just a patient case, so you have a sense of at what stage of this we're thinking about clinical questions related to treatment optimization of TMS. So let's imagine you're the psychiatry provider for a 26-year-old male, the interventional psychiatrist who has treatment refractory depression, comorbid anxiety disorder, chronic musculoskeletal pain due to Ehlers-Danlos syndrome, and has a history of physical abuse by his father, no PTSD that he reports. He's been on antidepressants since age 13. His only treatment response after numerous antidepressant trials was to ketamine infusions when he was 25, and he relapsed pretty quickly after that. And since then, he's tried 3 medications, and he's been depressed for about 6 months, and things are getting worse. He's stopped working. He's experiencing constant passive suicidal thoughts. He's been seeing a therapist off and on, but he just stopped going and stopped really all his treatments because he didn't find them helpful. He has a family history of a father who had received ECT and also a mother and brother with depression and anxiety. He specifically did not want ECT, partially because of the relationship with his father and not wanting to view himself like his father. And so, like I said, he'd stopped all medicines except for vitamins and benzos. He doesn't want ECT, he wants TMS. So he starts the standard protocol. Now you're 2 weeks into treatment and he's not responding. So what do you do? So I want people to think about this for a second. So I don't know if we'll be able to have participant feedback here, but think about what you would do. I mean, you could change protocols, you could stop and do something else, you could continue. So hopefully everybody has something in their mind of what they might consider doing next. What I would argue you should do next is continue. And I'll share some data for why that is. However, you should think about, are there other ways we can optimize the treatment? And so this is the type of situation that I'd say I find myself in a lot in our TMS clinic, because 2 weeks is not a full treatment course, but when you're not seeing any signs of improvement, how worried should you get? And should you do anything different, or do you just stay the course? So I'll talk about some literature and my thoughts on that. So last section is new insights into optimizing TMS. And this will probably be the rest of the presentation here, and quite a bit of data. So hopefully it's not overwhelming. All right, so when I think about optimizing TMS, and I gave this similar slide at the NNDC conference this past year, I think about exercising the brain. So the same things we do to develop an exercise regimen for our bodies, in some ways seem to work for optimizing TMS for exercising your brain. So what do you do when you have an exercise regimen for your body? You might take supplements to help build muscle faster. So that's, I'd say, is the equivalent of like medications or therapy to try to enhance the treatment effect. You could think about it avoiding unhealthy diet or eating healthy. So maybe avoiding things that could interfere with our TMS effects. You could hire a trainer, and in the TMS world, I would compare that to like a more efficient treatment protocol. Maybe you just need to get more reps. Maybe you're not spending enough time at the gym. And so I consider that the same as these high-dose protocols like SAINT. What's the evidence for those? And then targeting the right muscle groups. So, if I want to get large biceps and I'm just doing squats all day, it's not going to work, right? So we need to develop these targeting protocols to engage appropriate networks. And these last two is where I'd say SAINT has done things differently, and I'll talk about the evidence for maybe which of those is the secret sauce. All right, so what are the supplements and deep fried Oreos of TMS? I'll preface this by saying adjunctive D-cycloserine is an off-label treatment. In most situations, I'd say most people don't use specific medications broadly to supplement TMS other than just having people on a TMS treatment. But what's the kind of exciting data that's coming right now? I'd say adjunctive D-cycloserine is one of the most exciting potential enhancers of TMS response. And so there's the study conducted by Cole et al. Out of Canada that showed basically this 39% remission rate at 4 weeks. Again, usually we do 6-week protocols with adjunctive D-cycloserine for the first 2 weeks of treatment versus patients that got a placebo only had a 4% remission rate. And so this was a 0.99 effect size. I believe they're working on replicating this currently. And here's the results of that study. So you see both at 2 weeks and at 4 weeks, you're seeing the people that got D-cycloserine, which is an NMDA partial agonist and NMDA modulator, seem to be responding better. And that makes sense because we do think TMS is working through synaptic activity, through NMDA receptors. So this seems to be a way to potentially modulate it. There's a lot of questions there, like, do you use it for more than 2 weeks? Do you use it for just 2 weeks? What dose do you use to optimize? So those things are still being worked out. How about the Oreo nose? What shouldn't you do? Benzodiazepines potentially. And there's not, I'd say, super strong evidence and really no prospective evidence for stimulants, psychotherapy, or benzodiazepines. But the studies we do have that are mostly retrospective suggest that benzos impair response, stimulants and psychotherapy enhance response. Here was a large study out of California that showed that people on benzos in general had lower response and remission rates than non-users, and stimulant users had higher response and remission rates than non-users. There's a bunch of potential confounders there, like are the patients on benzos just more likely to have other comorbidities that make them less likely to respond, et cetera, et cetera. But like I showed you, the data on predictors of response for these comorbidities is not very strong. So maybe there is something there. And I didn't show the data for psychotherapy, but psychotherapy seems to also enhance the response. There was one study, the Dance study here, that suggested, I think, up to like 75% of people who got concomitant psychotherapy had a response to treatment. So what was our consensus? Here's the language we used. You don't have to read all of this. The big take homes for people that are like, okay, so what should I do after you told me all that? I want to start a TMS clinic. Really, there's no demographic factors that consistently predict response to a degree that we would say, if you have X condition or you're on X medicine, don't get TMS. There's too much variability to say anything definitive like that. The one situation I'd say where the evidence is weakest is in depression with psychotic features. And those patients, I'd say across the board, are usually recommended to go to ECT. There have been case studies of them responding to TMS, but nothing that's been really systematically gathered. So depression with psychosis, ECT, other comorbidities with depression, TMS might be worth thinking about. So we'll get to like maybe how you incorporate that for like our patient case in a little bit here. All right, so what about more efficiency? In general, for people that aren't familiar with the TMS space, the protocols have gotten more efficient. And the way they've done that is by more closely mimicking the neural activity of the brain. So initially there was this 3,000 pulse 40-minute protocol, and there was a DASH protocol that cut that down to 20 minutes by just changing the amount of time between the stimulation trains. And then more recently, there's been this intermittent theta burst protocol that delivers 600 pulses in 3 minutes and seems to have the same similar excitability effect to a full 40-minute 10 hertz protocol. And 10 hertz and DASH have been compared and found to be really similar in terms of response rates. 10 hertz and theta burst have been found to be similar. I'll show some of that data. So the biggest study in the TMS world most people know about is this one, which was called the 3D study out of Canada. And 414 patients either got the 10 hertz protocol or the theta burst protocol. And you can see the response over time is like extremely overlapping. So the theta burst 3-minute protocol seems to work just as well. Some people said, well, that's one study. We need to replicate that. So we looked at our own data at Iowa in 105 subjects and found very similar things. So the response and remission rates in the 10 hertz and theta burst groups were extremely similar to the point where we feel very confident using the theta burst protocol for almost all of our patients, usually only limited by insurance companies. And then there are different TMS coils. Like I showed you guys, there's a helmet called the H1 coil that you put on your head. It stimulates about 6 centimeters deep into the brain. There's also the figure of 8 coils, which are the ones that just sit up against your head and stimulate just a couple, 2-3 centimeters deep. And I'd say the evidence for those is also early, but there's some evidence saying maybe if you stimulate deeper or more tissue, you might get a better response even than the superficial stimulation. I think the literature and the expert consensus, as I'll show you, in general suggests that they're largely equivalent, but that needs to be further looked into. And I think there could be several reasons why the deep TMS coils might work better, which we could talk about too. So a whole bunch of data, take home point, we're getting more efficient with how we deliver this treatment. And there's different ways to do it, but they all seem to work relatively similarly. So the faster ones are just better because they're more efficient. All right. What about more reps? So this kind of gets into back to the Saint protocol, and really the efficiency of the theta burst protocol is what allowed Saint to even come into existence, because theta burst got treatments down to 3 minutes per session, and then you could really start to stack them like Saint did into multiple sessions in a day. So one of the largest studies that looked at the dose response relationship of TMS was this study by Yu et al. And they looked at about 2,500 participants across a bunch of clinical trials. I will say, I don't think that they control in this for the way the stimulus was delivered. So I don't think, like, if it was theta burst versus 10 hertz, I don't know if that's controlled for here. But they looked at a bunch of studies to look at the effect of different aspects of the treatment. And interestingly, the two things that seem to associate with treatment were more sessions per day. So how many times you have the person sit down and do the treatment, and more total pulses per day. So if you had 5,000 pulses instead of 3,000 pulses, there's a trend toward responding there. Interestingly, pulses per session was not significant in this model, and total sessions was not significant in this model. So it's kind of hard to know exactly what to make of that. What if you did more sessions? You'd think that would associate with more pulses per day, but here it's the pulses per day and the sessions per day that seemed to be most associated with treatment response. So maybe more reps is better. And so what do we know outside of these large meta-analyses? What do we know from just registry data? And here's 2 other extremely large registry studies that were done retrospectively. The first one by Harold Sackheim and his team showed that the more pulses per session you do, the better the outcome. Here's number of sessions along the x-axis, response and remission rates on the y-axis, and you see, response in brown and remission in blue. You see that over time, there's a general trend towards higher response with more pulses. Towards the end, there is a little bit of a tailing off there, which could be due to the sample sizes diminishing. But and then more sessions per course also seems to have better outcomes. So this is a busy slide here, but in general, this is the number of TMS sessions each person got, and then colored by the total number of sessions in that person's treatment course and the response and remission rates. And so say the very furthest right line, the black line there, is probably the most important because those are the people that got the most treatment. And you see the response and remission rates just keep climbing. Even when they've had 40 plus treatments, the response and remission rates keep going up. So there's not a plateau that we know of for when people stop responding, or more treatment doesn't add more benefit. The I'd say flip side of that coin is maybe, although you continue to get benefit, there's diminishing returns, and I think there is some evidence for that. So here, that's the same study of 7,000 people, showed what is the percent PHQ-9 improvement per every session of treatment. In the first 10 sessions in all these groups, you're getting, about 3% improvement in the PHQ-9 for every TMS session, and that dwindles off after treatment. So they're still getting better, but they're getting better at a slower rate than they were in the initial treatments. And so this raised the question, maybe there's a point at which we can look at patients and say, if you aren't getting this 3% per treatment in the first 2 weeks, maybe we should cut you off and think about something else. So we looked at our data that was published in 2022. A couple other groups have done this as well, to look at, okay, if you don't get 20% better, so if you don't get at least some improvement in those first 2 weeks, what is your chance of not getting better long term? And about 70% of the people who don't get that 20% threshold will not respond by the end of the treatment course. What do you do with that information? I think it means you start thinking more aggressively early, but it doesn't mean you stop treatment, because there's still a third of people who will get better even if they haven't had early response. Insurance companies have taken some of that data to say, if they don't have this, we're going to stop paying after 2 weeks. So that's been an unfortunate downside of some of those studies. But like I said, I just think we need to start changing up things early. And I won't spend too much time on this, but this was a study that just looked at the question of how much time do you wait between treatment protocols? The Saint trial waits 50 minutes between every session. So you do a session, you wait 50 minutes, you do another session. That's based on this idea of spaced learning theory, where the brain kind of needs time to incorporate the neuroplastic response. So this study looked at, if I do 2 treatments and cluster them immediately together, or I do one and then wait 54 minutes and then do another, what happens? And basically showed that it didn't matter whether you did them together or you separated them. The treatment seemed to have a similar trajectory of response either way. All right. So what's the consensus on this? I'll abbreviate this for you, but basically we said traditional and these newer protocols like Theta Burst and DASH all seem to work pretty similarly. They're non-inferior to each other based on the data we have. Any of them are appropriate to use for TMS in a new patient. There is this evidence of dose response curve in the data. And so we use that to suggest maybe you need to finish your treatment course. You shouldn't stop early for most people. Whether that means we should do a Saint protocol for everybody, I think is still a huge open question. And so we don't specifically recommend Saint at this time, although it is a consideration for some patients. And then combining TMS with psychotherapy or medications can't hurt, and if anything, may help. So back to our patient scenario. You got 2 weeks in. We're at this point, now the chance of non-response is about 70%. So what do you do for these people? You keep going. How can you optimize treatment? So what we consider, trying to put this into a practical example, we would have a discussion with this patient about tapering benzodiazepines. Obviously, that could exacerbate things, and so it requires a nuanced discussion. But if the patient's not using it much or doesn't seem to need it, minimizing use could help. You could consider increasing the pulse count. There's some evidence for that, and evidence that probably won't hurt, if anything. We had, and unfortunately just lost, our psychotherapist who would see these patients, and we'd often place a referral to have our psychotherapist kind of work with them in between sessions, or potentially adjust, or in this patient's case, add a medication. And I didn't talk too much about this for TMS aficionados. We also reviewed evidence for, like, some people will do bilateral TMS and add on the other side, or switch to a low frequency protocol on the right side. Those things both have evidence, but not as much evidence as these other considerations I mentioned. Okay, it's a lot of information. Let's go back to chicken. I know this is lunchtime. This is probably the worst time to talk about delicious KFC chicken. So dose may be an ingredient. I think that we have some evidence that there is a dose response. More might be better. So I think that's at least part of the secret sauce of TMS. The next question is targeting. And this will kind of be our last section. I know we're running up against time here. So here's another KFC recipe I found on the web. Did they get it right? Oh yeah, they got the paprika, but wait, they got the celery salt wrong. So I don't know why people can't get this recipe right, but there's many KFC recipes out there. So targeting inherently matters. I think everybody knows that. If you played a shoot 'em up zombie video game, you know you guys shoot the zombie in the head to get points or to kill the zombie. So, like, targeting matters. If we stimulate the wrong part of the brain, we're not going to get the response we want. The question really is, how much does it matter? And that's what gets into a lot of the nuances of the SAINT protocol. And also, how focal is it? So here's an example from a macaque monkey. The top left image shows what the E-field model suggests is being activated, the areas in red there. So it looks like you're getting an area like 2-3 centimeters wide across the brain that's being activated. But when they looked in this macaque with electrodes implanted in the brain recording single neuron activity, the area of the brain that had modulation of neurons was about 2 millimeters of activity, that tiny red area there. So how focal is TMS? I don't think we know, and that's one thing we're very interested in at Iowa. I'll talk about some things we've been looking at to try to get at that. I will say, even if we only have a focal depolarization of neurons, we may have a distributed effect throughout the brain. So you might depolarize neurons, but also modulate everything connected to those neurons transsynaptically. So it's always something we have to keep in mind. All right. So again, history of TMS here for people that aren't too familiar. How do we target treatments if we don't use neuronavigation in the room? How this was done initially in the original studies was you found the motor cortex, which you can find because you stimulate and you cause the hand to move. And then you move 5 centimeters anterior. And that's just because on an average brain, if you go 5 centimeters anterior, you're going to be in the middle frontal gyrus, or brain regions that are considered the left dorsolateral prefrontal cortex. However, they found that was wrong about a third of the time. So then we started to use the EEG head measurement system to find the F3 electrode location, which is also prefrontal cortex on the left and takes into account the patient's head size and circumference. And I'd say currently those are the main things used in clinics around the country. In research settings, people will do things like anatomical targeting. In Canada, that's pretty common that people will get anatomical targeting, as a lot of their work is done in clinical trials. You could target based on brain metabolism. And so some of the early studies suggested the DLPFC in depression is hypometabolic. And so that's why initially it was targeted. And so you could target based on PET. Almost nobody gets PET imaging. You could target based on group structural connectivity, so like, or connectivity from a group average brain, basically, and get a general sense of the brain region that you want to stimulate. And then SAINT, which is my own functional connectivity in the brain using resting state bold MRI. So here's most clinical care, here's research, here's SAINT. So kind of a wide spectrum. So at Iowa, we're very interested, I'm very interested, our lab's very interested in this question of how do we target, what matters here, how do we know the way we're targeting is even rational and based on, well, do we think what's happening in the brain is actually happening, basically. So these are the ways that we study this in the lab, clinical trials. TMS with intracranial electrodes. So we take epilepsy patients who have intracranial electrodes in the brain, and we do TMS on them, which has been a multi-year process getting set up here at Iowa with a lot of collaborators. But it gives you this window into the electrophysiology of the brain that is really unprecedented for answering some of these questions. And then looking at brain lesions. So if you lesion a certain area of the brain, what can that tell you about the connectivity of those regions and potential downstream effects on mood? And so I'm not going to talk about the lesions today. I talked about that with neurosurgery actually when I previously came. Happy to talk about it another time, but I'll talk briefly about kind of our clinical trial and then our TMS IEEG work. Oh, and I see I got some questions. I'll come back to those just because I realize I blew way past their relevance to right now, but I promise I'll come to them at the end. All right, so different targeting methods find different locations. So this is kind of what I did in my fellowship at Iowa. The first question we asked was just, can people even find the same target day to day when you're just using scalp measurements? And you see the green is using the F3, or sorry, the 5.5 centimeter method. The red is using the F3 method. And in general, people have a lot of variability in finding those targets day to day. However, the F3 method in general, those red dots are statistically significantly more clustered together than the green dots. So F3 seems to be more reliable. But even more importantly, depending on where you go to get treatment, you're going to get treatment at one of these two spots, which right now we are billing as these are the same. They work the same. The efficacy, is probably the same. We don't know. We didn't have data on that. I'll show some data we have, but they're clearly not. They're about 2 centimeters different, and the spread of that TMS coil maybe is 2 to 3 centimeters at most. So we're engaging different brain regions. Here's kind of what I said. So the average distance between those two centroids was 2.5 centimeters. Here's the data showing that the reliability is better with F3. And here's a bunch of targets that are published in the literature saying like, this is the right DLPFC, dorsolateral prefrontal cortex spot you should stimulate for TMS. You see they're kind of all over the prefrontal cortex. So this is what got me interested in targeting and trying to figure out, how can we do this better? Which of these is actually the best? Blah, blah, blah. So if we think about this from a network perspective, which is kind of how Saint thinks about this, how a lot of other trials think about this. You look at where those targets fall, they're actually falling in different resting state brain networks. And I won't talk too much about those, but basically they're areas of the brain that have activity that ebbs and flows together. In general, this is again an average template brain, so this varies person to person. There's a lot of variability in network representation, especially in the prefrontal cortex. But this tends to fall in different brain networks, which is also problematic if you think about this from a network or circuit-based engagement perspective. And one other kind of tangential aside here is you also have to keep in mind this is a template brain. And we know that prefrontal cortex networks in depressed brains are different. So this purple area is called the ventral attention in this bottom image near the red circle here. And that's part of the salience network. And here, this large study conducted by Charles Lynch, which is bioarchived right now, shows that in general, the salience network is larger in depressed patients. So we may think we're stimulating a network, and in a depressed person, we're not. We're stimulating salience network because it's larger or something else. There's also work from the Saint trial that shows that the activity differences that you engage when you stimulate the DLPFC relate to the dorsal anterior cingulate and the anterior insula, which would also suggest, maybe we're engaging some salience network target. So take home there is just without doing personalized targeting, you might not engage the network you think you're engaging. And here's just more evidence for variability of different targets across different published studies. I won't spend too much time talking about that. So really this leaves everybody with the question, where do you put the coil? Do you target a brain region based on the scalp? Do you target a network based on these resting state networks? Does that network need to be individualized? There's a bunch of questions there. So we decided at Iowa to just start simple and say, okay, we have two common scalp-based targeting methods. Which of those is better? And first we said, maybe everybody agrees one's better and you don't even have to ask that question. So here's kind of the 5.5 centimeter method. Here's the F3 method. Here's kind of a special way for finding the F3 method called the beam method. And we looked at the old guidelines from the NNDC, which is what we're replicating here or republishing, and then also the Clinical TMS Society guidelines. And they disagree. So one says using F3 or alternative treatment parameters beyond 5.5 centimeter is not clearly established as a recommendation. And then in the NNDC paper, they said the F3 position is considered the preferred coil position. So there's a disagreement amongst the experts. And so we did a randomized comparative effectiveness trial, which we've conducted and finished up last year. Took about 3 or 4 years of data collection, where we just randomized patients that came into our clinic for depression treatment to one of the two targeting methods and monitored their depression and anxiety outcomes. And we initially powered this for moderate to large effect size with 200 people. And here's kind of the trial. Ben Pace and Brandon Neiswander were two people in my lab who did a lot of this work. And so we ended up randomizing 105 people, and you'll see why we stopped early. 96 of them got per protocol, which we just decided was 20 treatments or more, which is kind of the minimum general therapeutic effect for TMS. And in general, they were pretty similar across groups. There was more ADHD patients in the F3 group for just unfortunate randomization. And people had tried numerous medicines. It was a very treatment refractory group, on average about 10 medication trials in their lifetime. And what's the take home? They're 2.5 centimeters apart on average, these targets, but they work the same. So there's really no difference in efficacy on the PHQ-9 or the MADRS in these two groups. There may have been kind of a slight trend in the Beam F3 group for the MADRS improving sooner, but by the end of treatment, that caught up. So what about anxiety? And this was especially of interest to us because anxiety, there's suggestions that stimulating different parts of the prefrontal cortex may also alter anxiety differently because they belong to different brain networks. So we looked at our anxiety data, and there was kind of a trend towards the 5.5 centimeter group, which falls into this anxiety hub here, this blue and purple area of the brain, responding better. And you see that in general, the red 5.5 centimeter line here is improving more at most time points, but not statistically significant. However, when we control for depression, because obviously when depression improves, anxiety improves, there's a lot of overlap in symptoms. So if you control for the effect of depression, actually the effect of anxiety is stronger. Anxiolytic effect is stronger in the 5.5 centimeter group. So maybe that's a reason to choose one target over the other. There's actually a study underway to try to replicate that right now. Okay, so that's kind of the take home on scalp targeting. What about functional targeting? That's what matters for the SAINT protocol that we're trying to determine the secret sauce of. And so what do we know about functional targeting? There have been several now studies, small studies, retrospective studies that suggest if you look for this functional connectivity that's anti-correlated with the subgenual cingulate cortex, there's a lot of reasons for the proposal of that target I won't talk about right now, but the anti-subgenual cingulate target seems to associate with treatment response. As you get further away from that target in the dorsolateral prefrontal cortex, you get less and less treatment response. So a good amount of retrospective data supporting this functional targeting idea. What really needs to be done, and there's people planning these studies right now, is prospective comparison of functional connectivity MRI targeting to standard targeting to actually prove, is there enough or a detectable benefit to doing that MRI and additional targeting and additional cost to justify it's better than just doing scalp targeting. And like I said, the SAINT trial did find the targets were different, and they were pretty different from the BMF3 site in the brain. So this may matter. So the largest study really to look at this question took 295 people. This is still retrospective, and looked at the same question: how does anti-correlation with the subgenual cingulate cortex compare to treatment response? And so the title there is kind of the takeaway. Functional connectivity targeting matters for your outcome, but it matters a little. And what do I mean by that? It was significant, but the variance explained in outcomes by the functional connectivity targeting was 3%. So it was not very high. There's, I'd say, a lot of potential criticism for this. One of the biggest things being they did not use very large resting state voxels. So it's possible there's some blurring of kind of the connectivity in the DLPFC that might have made targeting less, or retrospective look at targeting less clear, but this is, at least based on current evidence, kind of the take home. Functional connectivity matters at least a little. Okay, so there's all these people doing retrospective looks at data that's already been collected, and that's all awesome, and we're learning a lot from that, but we really wanted to say, let's go back to not putting the cart before the horse and just say, okay, what are the mechanisms here? What's happening? We can answer a lot of these questions with this really unique TMS intracranial EEG method, where we can stimulate and actually look at focal areas of the brain with an intracranial electrode or a depth electrode to say, are we getting an evoked response in these areas? How does network connectivity play into this? So here's kind of an example of one of the epilepsy surgery patients who has electrodes implanted all over the brain for epilepsy monitoring. And we come in while they're in the epilepsy monitoring unit and do TMS while they have the electrodes in. We've done a ton of safety data to kind of confirm this is safe, which was a big question initially. And so if we stimulate the DLPFC like we would and target it just like we do for depression based on scalp targeting, what happens? The areas that activate are the dorsal anterior cingulate and the anterior insula, which is really interesting. That goes back to this idea of the salience network that's large in depression patients. That seems to be the areas that are activated in these epilepsy patients with TMS applied. There's a lot more to this paper, and this is a very complex study that was a collaboration between us and Stanford, and it was just literally published within the last week in Molecular Psychiatry, so you can take a look for further details there. Okay, I think this is my last slide, then I'll open up for questions. So do TMS pulses travel in resting state networks? So this gets to the basic question that is foundational to studies like SAINT. If I stimulate the brain, is it actually propagating in the resting state network, or the network I expect based on functional connectivity? And this is something that's really hard to answer with EEG data. It's hard to answer with fMRI data because of the spatial and temporal specificity. So it's something we can really answer best with intracranial data. And so we can get an individual patient's resting state. Each of those black dots on there is a depth electrode in an epilepsy patient going into the brain. So we're recording from a bunch of places here in the left hemisphere. And we can stimulate and look at what happens here. So what did we find? I'd say in general, our hypothesis that pulses travel in resting state networks was confirmed. And so if you look at when I stim and I look at other electrodes that are in the same network in which I stimulate, they are more likely to have an evoked response than electrodes in out of network brain regions. And we had kind of did that analysis 2 different ways there and showed the same idea that functional connectivity matters on an individualized level for predicting where treatment effects are going. All right, so let's get back to practicalities. That's a lot of like really deep information there. Consensus, what do you do right now? So based on our study, we really recommend that actually 5.5 centimeter and BMF3 seem to work equivalently for targeting the DLPFC for depression. Anxiolysis, I think, is still up in the air. I don't think our study was definitive in saying if you have anxiety, you should use the 5.5 centimeter target. But in general, they seem to work equivalently from what we know for depression. Functional and structural targeting. Right now, we have the SAINT trial, which has been positive. Further research is needed, I think, to confirm that and to really validate the level of importance of that functional targeting. I'm a huge fan of MRI and targeting, but I think we need more data to validate how important that piece is in the secret sauce. So what's the take home? Maybe the world's just not ready for the secret sauce. Here's 2 more recipes I found on Pinterest and some other sites. They're both wrong too. I don't know why people can't get the secret sauce right. But the colonel is protecting his secret sauce apparently. So future directions, we're continuing our TMS IEG work. I think SAINT has the advantage of being 5 days and something you can do in the inpatient setting. So we're going to be one of 4 sites for an inpatient SAINT trial for suicidal patients in the hospital. You guys might have the same problem we have. This is not Iowa. This is a hospital in Israel, actually, but we have the same problem in Israel and in Iowa, which is patients are in the hallways. We can't get patients in and out of our units as fast as we want. And so rapid acting treatment like SAINT on the inpatient unit might be very useful. And then we have ongoing studies looking at TMS for anxiety, and also looking at hopefully getting this NNDC work published soon, and you guys will be able to see the rest of these recommendations later this year. And I've said all of this stuff, so I'm just going to fly through my conclusions. Mainly, TMS is a mind-blowing treatment for depression. Hopefully you take that away. And the other stuff is all stuff we've already talked about. So, oh yeah, and I put some extra chicken in there for the end of our lunch hour here. And we're hiring always at Iowa for both research and clinical positions. If anybody's looking to move further north and into the snow, here's a bunch of people in our lab, and also me and my wife and our youngest daughter at the Field of Dreams, which is only about an hour from Iowa City, from the old Kevin Costner movie, but they play actual baseball games there, which is kind of cool. And here's our lab, so I'm happy to take questions. Maybe I should start with the questions in the chat here. All right, so Audrey asked, do you have any experience with using TMS in pregnant or postpartum women? I've read some of the open label studies. There's not a lot of data out there that I've been able to find. There's not a lot of data for that. In general, the data suggests that it's effective and it's safe. The Clinical TMS Society has actually created a registry. So if you do treat any patients with TMS with who are pregnant or postpartum, you could, I think, put their data onto that registry if the patient's okay with it, to get more information in that regard. But yeah, most of that is just at the level of case series and open label studies right now. Any retrospective data on stimulants or cycloserine effects on switching? I assume this is effects on switching people into mania. If I'm misunderstanding that, please correct me, anonymous attendee. But there is not evidence in TMS for whether those things would induce switching. I think in general, stimulants actually don't have that strong data for switching, but there is some. So if I'm misunderstanding that question, though, please correct me. Any thoughts on focused ultrasound for mental illness? Yes, a lot of thoughts. We actually just got a focused ultrasound device at Iowa. There's not been a whole bunch of studies. I think it's basically at this point still at the level of safety. So the mechanism for focused ultrasound is proposed to potentially be altering ion channels through mechanoreceptors. So you're kind of vibrating the brain and altering the permeability of ion channels, which causes excitability changes. And that sounds scarier to me than just depolarizing a neuron with electromagnetic energy. And so there's a lot of work going on safety-wise. There are some studies looking at that, I think, especially with depression, anxiety, OCD, but mostly at the feasibility and very early stage level. Happy to answer any other questions. Hopefully people were okay with all my chicken references. Oh, here we go. Dr. Wang, in your F3 versus 5.5 study, there's more ADHD patients in one group. Any concerns that psychostimulants may have played a role in making one method more effective than the other? We could go back. I think I have on there the stimulant usage across groups. See if I put it on the slide. Here we go. So even though there was differences in the ADHD, stimulant usage was higher, but not statistically higher in the F3 group. Could that have played a role? That's a really good question. I don't know that we can answer that, unfortunately. In general, I don't think it would have changed the outcome of the study. And the reason I say that is, like I said, this ended at 105 people instead of 200 because a prelim or a interim analysis demonstrated this was not feasible, and the sample size we would have needed based on our first 100 patients to have any chance of detecting a well-powered study for a difference was going to be on the order of thousands of subjects. So it could play a role. I don't think that it would change the outcome in that study, but it's a really good question. Awesome. Well, thank you guys for your attention. Hopefully I'll come in person sometime. It's always harder doing the Zoom lectures when you can't see people, but
Hey, Nick, thanks for coming back to U of L for a talk. Nice to see you again.
yeah, it's good to see you, Ali.
Yeah. Hey, a question. So there is a question from Lee Giles, one of our clinical pharmacists, about D-cycloserine, and I'll let you kind of read that.
Oh, sorry. Yeah, didn't
Oh,
see
that's okay. One of the questions that I also had as a complement to that question was, you know, in our practice, we've been using a lot of actually ketamine supplementation with TMS as well, because we know we kind of enter into a kind of a transient neuroplastic state with ketamine and S-ketamine. So any thoughts on supplementation or kind of using other types of supplements, whether it's nutritional supplements, whether it's other types of medication supplementation with TMS? That's question number one. Question number two is, have you noticed any, or what are your thoughts on, you know, kind of the wave of the dissociatives in the use of psychiatry, whether it's ketamine, S-ketamine, or, you know, in the future we're looking at psilocybin, we're looking at MDMA. Any thoughts on how that might change to either complement or not complement TMS? Because I know that because I'm on the NNDC task force for ketamine, and we've talked about lamotrigine and kind of interfering with the neuroplastic response associated with S-ketamine. Any thoughts on, you know, what do you strategize or do you think about ways to, in addition to cycloserine, either ketamine or something else like SAMe, NAC, whatever, to kind of give the folks a boost?
Yeah, really good question, Ali. And yeah, you guys are doing always novel stuff over there, which is awesome. No, I've actually, you probably know Mark Nishu, who's our colleague on NNDC Ketamine Task Force, and I work pretty closely with him. We've spitballed those exact ideas, which is, you know, we should do a study, TMS combined with S-ketamine. Could be really interesting to see if you can enhance the neuroplastic effect. You know, there's all these other things we're doing to try to enhance that effect. Makes sense that way they would work together. There is some evidence from like the TDCS literature and these other areas where there is like this idea of like calcium flooding, right? Where you can overstimulate the brain and then potentially impair the effect. So I think that's something to watch out for. We will recommend things like SAM-E, but more in like a TRD space, not in a enhancing TMS space. And that's just because we're usually relatively conservative with things. So like my go-tos are always, can we get them on a lower dose of benzos? We don't really use stimulants, but could we in some way augment their treatment? Sometimes, we'll use medicines like Auvelity. I'm sorry to use a brand name here, but to see if there's an enhancement effect there. But I don't have any data beyond anecdotes for those type of things. So it's a good question. And then your second question was, sorry, say that again.
Oh, that was kind of the main thing, is if you use anything. Oh, I guess the second question is, have you no, that was pretty much it. Actually, the other question was kind of more geared towards something else, but I just realized that I don't need to ask that here. But yeah, that was pretty much it, is if you were using anything to help augment the TMS neuroplastic effects. Kind of a philosophical question for you, actually. There was I've been looking a lot about and reading a lot about the substrates for resilience in the human brain. And we know that with certain TMS protocols, priming is quite important, right? So like we know, for example, for OCD smoking cessation, you really have to prime the patient prior to the delivery of the stimulation. And there's some studies out there on using theta burst priming prior to a 10 hertz treatment as well, which is kind of interesting. What were your thoughts on priming in terms of depression? One of the things that we've toyed around in our practice is, if we are kind of priming your default mode and resilience sort of thing, do we, if that's what we're stimulating with DLPFC, should we be priming our patients into an antidepressed state by either, using some kind of supportive psychotherapy type of situation early on, or kind of motivational therapy before initiating or doing our regular TMS? Or should we be actually priming a little bit of depression, kind of what we do with OCD, where you prime a level of, you get the patient a little bit obsessive, et cetera, and then you place them in the chair for your ventromedial prefrontal cortex stimulation. Any thoughts on priming? And if you think that it would be helpful, which way do you prime? Do you prime for antidepressant or do you prime for depression?
Yeah, it's a really good question. So I heard, I don't remember if it was Mark George, somebody had mentioned to me the reason you don't need to prime in depression is because the person's already primed. They're coming into clinic, they're already depressed, they're already ruminating. So they're kind of coming in a primed state, whereas OCD, we're kind of priming people. I think that's interesting philosophically. I think there's something there with priming. It gets tricky because I know there's some people that have done like priming bilaterally. What if you prime the opposite side of the brain? Does that matter? Is that going to be the same network? Those are hard things to answer. We have done some priming studies in substance use disorders and have gotten good effect, and two not large enough samples to say, but it does seem that the order of how you do that priming probably matters for reducing cravings and things like that. As far as how that fits in with all of our network-based stuff, I think there's these studies going on of OFC stimulation that Jonathan Downer's doing, which is kind of engaging this non-reward circuit. It's super interesting. We haven't done any of that yet. I'm super interested to see where that goes literature-wise. I know I think had a couple of patients who had detached retinas, so that might be something people are going to need to pay attention to with stimulating close to the eye. But super interesting questions. I know we're out of time, so I'm sure I could talk with you on this for a lot longer, but great question. Should I stop, or I'm happy to stick around and answer these last few questions for people that want to stick around, but oh my goodness.
I think it's okay if you would like to do that. Otherwise, we are out of time. So if anyone needs to leave to, make a 1 o'clock appointment or that sort of thing, we could go probably 5 more minutes or so.
All right, I'll finish up answering these. Thanks everybody for joining, and I can't tell how many people are on no matter. Oh yeah, I can. So if you drop off, I don't care. But thanks for sticking around. So how do you determine which TMS patients get D-cycloserine? What dose duration do you use? Do you supplement B complex vitamins with D-cycloserine? Great question. So right now, this is not clinically used. My understanding is this is not an easy medication to get. Even for the clinical trials, they were having trouble getting some of this medication because of pharmacies not compounding it or changing. So I don't use this at all clinically. This is just an exciting potential in my mind. I mean, it seems like it's a relatively safe medication since it's an old antibiotic. The studies have used, I think it's 150 milligrams daily for the first 2 weeks of the treatment, and I think dosing about an hour ahead of time. It's all in that one paper that I referenced, but I would stick to that because I think there have been that group has done some work on trying to find the dose for that to find which works best. So there's a lot of questions still as to how do you modulate that in a way that's going to be effective. And we don't supplement B complex vitamins. I'd be interested to hear your thoughts on that, Lei, but maybe something we can chat about another time. Next from Bhumika Shah, I have noticed some patients that are hesitant about neuromodulation when it would be beneficial for them. What advice do you have for patients considering TMS for depression? What resources are available to help them make informed decisions about their treatment? Yeah, it's so lack of access is a huge problem, and lack of understanding amongst both providers and patients is a huge problem. Those were like in our barriers section of our paper, those were like the 2 top things that were preventing more people from accessing these treatments. So I think there's a lot of resources online. We have some at Iowa. We've developed like pamphlets and things to say like, how do I think about TMS versus ECT? What are the side effects? What kind of things go on? What does the course look like? And I think all those details help. Some of our patients who are very anxious will just come in literally for a consult to like look at the device or see us do the device for practice on each other, things like that. So in rare circumstances, we'll try to just normalize it a little bit for them. Yeah, I think it's a lot less scary than it sounds once people see it. A lot of people are scared about the idea of you're going to stimulate my brain. No thanks. But when they see it, they're like, oh, this isn't so bad at all. I barely feel it. And when you think about the alternative of medications, which have more side effects in general in TMS, a lot of patients are pretty happy with it. And we're happy if you want, we can share some of those resources. We're hoping to get them up on our website soon, but I don't think they're up there yet. What role do you think exposure to fMRI plays in the studies you discussed? Do you think there's any cumulative effect? So I know there's been some literature on just like low field magnetic, like exposure to low magnetic fields, or maybe even stronger magnetic fields from MRI. That really hasn't borne out that antidepressant effect is very prominent. So if that's kind of the question, I don't think the MRI itself is having much of a therapeutic effect. Do I think there's a large placebo effect from showing people their brain and all this fancy targeting? Absolutely. There's these studies that show the placebo effects of like 30 or 40% in terms of remission rates for people just getting a protocol with sham TMS. So there's a huge placebo effect. And all these studies are sham controlled. Like the Saint trial did demonstrate that its blinding was successful in asking patients about their thoughts on the blind. There was a small sample of the people that didn't get blinded in the exact same way as others. Happy to talk about that another time, but in general, the blindings were successful. And so I think there's a large placebo effect, but also a large therapeutic effect on top of that for some of these treatments. Okay, I think I've answered everybody's questions, but please feel free to reach out. It's great to see a lot of interest in this space, and hopefully this was at a good level and not too deep or too superficial for the audience here. But That's great.
Nick, if you'll allow me a quick interjection, and for Bhumika's comment, I've found like it's really beneficial to introduce the options that are appropriate and effective and evidence-based early in the treatment of the patient. So usually my first evaluation of the patient, I'm telling them kind of what our game plan is about how we're going to try to use multiple different modalities to try to get that patient to remission. And I talk about TMS. So one of the, if we kind of approach things sequentially, then by the time that we get to TMS, a patient, if they're treatment resistant, might become kind of jaded, kind of not fully bought into the fact that they can get better. But if we talk about the fact that this is an option earlier on in treatment, and this is not only an option, but a valid treatment that would be a step that we would take if some of the initial first line things that we try don't work, then folks tend to be a little bit more receptive to it. And I use a cancer model for this a lot. I tell, when you come in for cancer, you say, hey, listen, we're going to do chemotherapy. We're going to do this, that, and the other. If that doesn't work, we've got some clinical trials for you as well to kind of reduce some of the barrier of hopelessness associated with non-response with some first line treatments. But thanks Nick for coming again, man.
Yeah. And to add to that, I think our TMS program actually destigmatizes our ECT program for a lot of these people too. A lot of patients who would never consider ECT, once they've been with us for TMS, maybe it doesn't work, then we've had time to kind of talk to them about those things. They're much more receptive to it. So.
Thank you, Dr. Trapp, for coming. We really appreciate it. Presentation was fantastic. Do you mind if I share your email with our residents in case they have further questions?
Yeah, absolutely.
Awesome.
All right. Thanks, guys. Nice to see you again, Megan.
Of course. Have a great day.
You too.
Thanks.